Welcome back to the most audacious EMS podcast on planet Earth, the Paramedic AF Show. We're here to challenge, encourage, and sometimes hurt your feelings. This isn't for the weak, the woke, or the apathetic. This is a show for the ones who show up and give a damn, the bold and the brazen. So stand up, stay vigilant, and enjoy the show. Do you need more coffee before we get started?
No, I still have half a cup.
Do you need more?
No, I really don't. It's fine.
Hey guys, if you can't already tell, Michelle had a little bit of a rough night, so she is nursing the caffeine this morning.
I mean, I do every morning, but this morning it's helping me more than survive.
What a glorious morning. If you didn't catch that reference, I feel sorry for you. Anyway.
You're too young to be watching this podcast.
For real, though. Even our kids know what that is. But anyway, hey guys, it's been an interesting weekend. We're recording a little bit later than we expected to because life.
Mm-hmm. But later in the week, but if you can't tell by the beautiful sun, we're actually recording in the morning time, which we don't often do.
I love it though. Like I'm seriously like, because God, sometimes at night, I mean, we do fine, but it's like, oh my God, we're dying.
Well, but with our schedules, is normally just not possible.
Well, yeah. Well, we might just start pushing the release date back to like Mondays because we can find some time on a weekend morning usually to do something probably.
Mm-hmm.
But anyway, we'll figure it out. It's been an eventful week on TikTok, and we have loved the response from you guys. I did find out apparently there is a TikTok ban that is still working through Capitol Hill. It's passing Congress, and it's going to get taken up at the Supreme Court apparently.
That's
so
wild.
Yeah, so this might be short-lived, but we'll still be on YouTube. I'm very interested to hear what you guys are going to do if TikTok gets shut down. Like, where's the next place to go? Obviously, I love long-form content like this. So YouTube, I'm happy as a clam on YouTube. But for those of you who don't enjoy that, I'd be very curious to know where you're going to land up so that we can go find you there. But as you've seen, we have had this guy, I think his name's Travel Merson, I think was his handle.
Something like that.
A lovely little rage baiter, which in general, I'll sit back and laugh at and be like, wow, that's a miserable existence right there. And honestly, the only reason I commented on it was I normally don't go to the For You page on the Paramedic AF TikTok. I just don't, because it's all EMS stuff. And I'm like, well, if I'm going to waste some time, I kind of want to, see other funny shit. But I just happened to switch over to my For You page and see this guy. And I was like, whoa, wait a minute. What the fuck? Who crawled out of his basement for this? So anyway, it was delightful. And of course, he says all these things about first responders, police, fire, EMS, military.
That our jobs are too easy.
Oh, yeah.
We shouldn't be asking for more money.
It takes 6 months to become any one of you. Okay.
Your job is too easy. I could do it.
Okay.
Give me a hose.
I'll just respond with one word: intubation. Fuck you. And don't and we have put this disclaimer out, and I want to make it very clear. We know that he doesn't represent the majority of you nurses out there, but also we don't hate the nurses. No. Yes, we have all had bad experiences, but we also know that you have had bad experiences with paramedics and EMTs. Yes. And that's not right on either side. Yeah. And we are trying to speak to those issues. We internally, the whole point of this show is we're trying to deal with that stuff. And
on our end,
yes, we're trying to deal with the paramedics and EMTs that are making us look like shit. Mm-hmm. I mean, us as a profession. So we hear you. We know that there's problems out there, but what this guy is doing is purely just rage baiting and isn't actually contributing to solving the problem. He's like, oh, well, now you guys know what it feels like.
Well,
okay.
Well, I would say that was, so in the first video, it's rage baiting. He basically talks shit about public service and military as a whole.
It was kind of rage baiting for me for the second one, to be completely honest, in a different way.
Well, yes, but the video straight up was talking shit about public service and military. Then I guess a bunch of people got on there and attacked
Good
him
for y'all.
in the comments. Yeah, good for you. So then he made a second video that was basically like, "Oh, did your feelings get hurt? Good. Now you know what I experienced, but it's your problem because you should have known that it was sarcasm and satire." And we're like, "But even your description was confrontational."
Oh yeah.
There was literally nothing about it that said anything about, "Oh, haha, just kidding," or like, "I hear this all the time." That's not you guys. Like, and then he tried to be like, "But we're a team," even though he never actually apologized.
That was
for
the
talking
most
shit.
god awful, half-hearted "we're a team." Like, and it was such gaslighting. Like, and I don't like throwing around that term a lot because I think it is overplayed. Just like narcissist is overplayed a lot.
He was gaslighting.
He was fucking gaslighting the house. Oh, well, because apparently some of y'all got offended for some, fucking reason or whatever. Like, yeah, fuck you. It would not have been hard to say, hey, like, I genuinely didn't mean to come out and say something positive. Just say, hey, like, I appreciate you guys. I respect you guys.
I think he said like, "Oh, I know it takes forever to get your medic," and that was like the closest. That was like the closest thing to a compliment, because he basically, it was an apology without being an apology. It was, "I'm sorry you got offended, but you're the one that didn't understand," even though he never actually said,
"Oh yeah,
sorry."
Oh yeah, no, he never said sorry. And which okay, I stick to my guns on shit. So I mean, if you're gonna say shit like that, okay, stick to your guns.
But he doubled down.
Well, yeah, but we're gonna come after you if you do. Don't expect us to be like, oh, okay, well that basically counts. Nope, it doesn't. If you're gonna put shit out there, be willing to deal with the blowback from it.
Well, so we just had 2 comments.
Well, we had a lot more than that, but today we only.
Well, yeah, Daniel made a TikTok on his first, or stitched his first video. I stitched his second video with feedback, whatever. And some of the numbers that I put out there are very generalized numbers, just as a disclaimer. But the 2 things that we wanted to talk about today is clout, because one is rage baiting for clout, if you look up the definition of clout, but then was turning around and accusing other people of stitching his videos to rage bait clout, or to get clout from rage bait. Like, gaslighting, propaganda. So we just had a couple little comments on it.
Well, and I'm gonna read. So there's a common quote that a lot of us hear, which is, especially in politics, which is, accuse your enemy of doing what you're doing yourself. And it's attributed to Karl Marx, but when you dig down a little bit, it's more just a colloquialism that's been drawn from a lot of sources over time. However, there was, let me take a look here. It was a book published in 2017 by a British journalist, Peter Conradi, and it was about Russia, and specifically, Russia during the Cold War, a lot of the Russian propaganda techniques under Putin, and he sums up one of the propaganda tactics used by Russia, which is accuse the enemy of doing what you are doing to confuse the conversation. So immediately, his apology, more like a response video, was immediately basically saying, oh, well, if you disagree with me or if you're responding to this, then you're clout seeking. No,
he put that on a comment underneath your video that said you were clout seeking.
No, but he did it in the response video too.
Oh, I guess I do remember that.
Yeah, he immediately just starts throwing that at everybody. And it's like, dude, what did you expect? You're going to insult literally hundreds of thousands of people with no context. It's not like we're in a comedy show, and I understand you should never take the internet too seriously, but it's generally a mature thing to do, that if you're going to potentially alienate that size of a group of people, you should probably throw some context in there. Just a little bit. It's not like, it's an episode of Kill Tony. Like, there's some understood context that you're going to be insulting anybody and everybody. But when you're repeating things that are not just inflammatory, but are often touted as truth, and then you're going to spin it around and be like, oh, well, if you disagree with, you should know, you should understand. We're not mind readers. What is he? Okay, that was about to be really, really rude. But like, what does he expect us to be? Like a mind reader? Like, I don't read your fucking mind. Like, sure, I got a touch of the tism, but like, there was no context for that. So yeah, you should expect this blowback. But this whole like, oh, you all are just clout seeking if you're, responding to this.
Gaslighting.
Like, dude, really? Really? So anyway, he's he put that out, and I think he just couldn't handle the fucking blowback. Like, really? I mean, he let that sit there for a day, got the attention, and then was like, "Oh, you should have known." No. Anyway,
So we just wanted to bring that up. That those 2 videos are on our TikTok pages. You can go back and watch his videos. I honestly scrolled through his page, and literally the only videos that got 15,000 views were the ones where he was like rage baiting and saying like crazy stuff.
Yeah.
There are people out there, but also keep in mind the internet is forever.
Yeah. Yeah.
And we are a tight knit group of people. So
Yes.
for today's actual content.
Yes. So instead of doing just a straight Q&A episode, we want to just sprinkle feedback from people across multiple episodes. So we got a message from someone who is a practicing paramedic in the field. Our policy historically is even if someone gives us permission to use their name and stuff, we're not going to.
Mm-mm.
Obviously, if you post a question publicly for people to see, cool. All right. Fair game. Like, you put it out there for the world to see. But this was a message. So it's lengthy, but it has to do with overdoses and how we treat overdose patients. So I'm going to read the whole thing, and then we'll just kind of talk through it, because I know we both have feelings about this. We both run, I couldn't tell you how many overdoses. So this is a good conversation to have. All right. So she says, in regards to your video about good topics, the general synopsis is about the stigma with drugs/medications, the way that overdose patients are treated, and the refusal to treat pain by a lot of medics. It's not fair to talk to/about someone poorly because they abuse drugs. They're human, and it's not fair to have a, quote, punch card mindset, essentially stating that after they've been treated for an overdose so many times that they don't deserve Narcan. Another thing in the same ballpark is how many medics absolutely refuse to treat pain and often attempt to toss these calls off onto their EMT. The thought process of, quote, their drug seeking is insane. Nobody can truly determine whether someone is or isn't, quote, seeking. If you treat them and it turns out they were, so what? It's in a controlled environment, and what is the issue other than hurt pride? An extra bit of paperwork? A couple more vitals? And if they aren't, you've treated them appropriately and with decency. I don't believe there should be a debate on who does and doesn't deserve analgesia when there is no way to determine whether someone is in pain other than the patient telling you. Drug addicts are not animals, and not everyone that tells you they're in pain is trying to, quote, get one over on you. I could go on for hours about both of these topics, but we truly need to let go of the mindset that pain management and the treatment of overdoses, no matter how often, is not a part of genuine healthcare. Initial thoughts?
So many.
Okay.
Well, I guess the question is, do we want to talk about it together, or do we want to separate the pain management and
I think
the
we should
OD?
separate it. I think it
So-
is. I mean, they kind of go together, but they kind of don't.
Well, so might as well go with pain management first, because you also made a TikTok that got a whole lot of fucking attention.
Which would, if someone could say that is against what she's saying, but it's not actually. But go
Well,
ahead.
no, it's not.
Not directly.
Sorry, so many thoughts. I cracked the drug seal not so much recently. It's actually
All the
been
time.
well, I was to say recently it's been kind of a weird dry spell, but I literally had the reputation, not even reputation, but just it was well known that I was such a black cloud at one of my jobs. Every shift they would come in and be like, "Good morning. Is the drug seal still the same?" And I'd be like,
Nope.
"No." So like I am not one to withhold pain management,
Mhm.
like when appropriate. But with the opioid problem and being a clinician and different medical conditions, opioids are not always appropriate,
Mhm.
especially if the agency carries Tylenol or Toradol. I'm not saying that we completely ignore and be like, "Oh, well, you can't be in pain." It's like, okay, but let's take kidney stones for example. So many people will, obviously, if your service carries the medication, but if you work at a service kind of like we did, that has, a wide range of medications, opioids are actually not the most beneficial for a patient with kidney stones. It's going to be Toradol. So am I hateful for giving Toradol instead of an opioid? No, it's inappropriate pain management. Same with sometimes giving Tylenol instead of an opioid, or fentanyl versus morphine versus ketamine. I love ketamine.
Mm-hmm.
And judging it, I gave a patient ketamine over fentanyl, even though fentanyl should have taken care of his pain because ketamine lasts a little bit longer and we had a longer transport. So it's about being a clinician and not just looking at somebody and being like, oh, you don't deserve this because of blah, blah, blah.
Yeah.
I'm all for the services that carry the nitrous oxide, but it really pisses me off when you have, because I worked with a paramedic at a service. I was still an EMT. This grandma had been in a car wreck and had an obvious fracture of her wrist. And he literally said, well, I'm not breaking the narcotics. We carry nitrous oxide. I'm all for if it's a BLS crew or like if you want to use nitrous as like a bridge until you start an IV and give the opioid. But and yes, it does take care of the pain. But I also like to think about the patient's pain when they stop breathing the nitrous and have to sit in the ER bed waiting for a doc to come see
Mm-hmm.
them, wait for, the nurses that are busy and probably have an obscene amount of patients
Mm-hmm.
to then turn around and get the pain meds. Now, not always knowing if somebody is drug seeking for like a bullshit complaint, I'm not going to give fentanyl to somebody who's complaining about their toe and they're
Yeah.
obviously strung out on something. So you can be in pain. Now, if it's like, broken or like, falling off, that's one thing. But I'm talking about like there was a patient that came in and literally his complaint was, I've been walking for 5 miles and my feet hurt. Okay, you can have some Tylenol. Like I'm not giving you fentanyl
Mm-hmm.
for that. Have you fallen? Is there a possible break? Is there any swelling? Is there redness? It's about doing a full assessment and making the appropriate pain management treatment because what is everybody including EMTs taught in school? Sometimes positioning is all you need to do to take care of pain.
Well, and I think to differentiate between how we interact with these patients and how we assess them.
Yes.
So you should always go out of your way to treat people professionally and with respect. Now, I don't care for the philosophy that says, "Oh, you need to treat everybody like it's your grandma." No, I don't. If you are yelling and cussing and screaming at me, we're going to have a very different conversation than if I was talking with my grandmother.
I mean, yes.
I mean, if my grandmother was cussing at me too, then I would still push back on her and say, "No, it's not appropriate for you to talk to me like that. I'm not going to tolerate that." Because that is, it treads the line of it can become actual abuse and assault because technically assault is verbal, battery is physical.
Yes.
So no, I will not treat someone, politely, tenderly, sweetly who is verbally assaulting me. That will never happen as long as I'm alive. Period. The end. Now, that said, just because you're annoyed with somebody doesn't mean you have the right to be a dick.
Mm-hmm.
If someone's in pain, you can acknowledge that. Be like, hey, I'm sorry to hear about that. Let's talk more. Tell me more about it. And I disagree. I disagree with the statement that you can never truly gauge whether someone is actually in pain. And now I understand that there's outliers. And part of understanding that is understanding patient's history, what medications they're on. Yes, someone who deals with MS or PCOS, something like that, their pain scale is going to be different. So that all needs to be taken into consideration. That's all part of assessing the patient. Vital signs are, aside from visually what you can see, if someone has, bones sticking out or had a bone sticking out, it's one of my more memorable fracture calls where the dude fell in the locker room shower and his tibia poked through his skin and then poked and went like slid back under his skin. Oh yeah, he was hurting, and he got all the pain meds. And I equate this, and I've said this in some of the discussion that we've had on some of the videos on TikTok, that I liken it to respiratory distress. Just because someone utters the words, "I'm having trouble breathing," that doesn't mean that there isn't actually something else going on, that isn't, I wouldn't say isn't physiological, because obviously the respiratory rate's increased, but a panic attack does not need an albuterol treatment by itself. You can have people who are having a panic attack that are also wheezing. So that's what I'm saying. It's clinical care comes into play, but not just because someone says, "Oh, I'm having trouble breathing." Okay, that doesn't mean I need to put you on a CPAP or prepare to intubate you.
Mm-hmm.
There's a sliding scale, and same with pain. It's assessing the patient's behavior, assessing the story, assessing their clinical presentation. And like you said, you don't have to use the same you don't have to use the same stick for every problem. Like, you can use different size sticks for different problems. So you can still do that. You can still go down that clinical pathway without being a dick, without treating people like shit. So I think that's a distinction, that's a nuance that we lose in this conversation. Because most people, why do they not give meds? They don't want to do the paperwork.
Yeah.
They're annoyed. And no, if the patient doesn't actually need it, if it's a 22-year-old that stubbed his toe at 2 o'clock in the morning, I ain't giving you, no, sorry, I'm not giving you fentanyl. I'm not doing all that because it's not appropriate. So treat your patients appropriately, but also we should encourage clinical discretion. So I don't disagree with what she's saying. Like, I understand what she's saying.
Mm-hmm.
I guess my counter would just be more nuanced. It's not a zero sum. You either have to treat everybody with pain management or you don't. I think it's more nuanced than that.
Well, that's why it's such a gray area. There's no one correct answer, because I could share a call that the two of us would run differently. Maybe you would choose fentanyl, I would choose morphine, which I almost never choose morphine. But
never in my career.
The only times I've given it, I gave it once for a STEMI, and then like maybe a handful of other times just because the hospital and an interfacility had initiated, and I was just like, okay, whatever.
Yeah.
Sorry, sidestep. But with the gray areas, I could describe a call and you could have run a very similar call, but the patient could have been on a beta blocker, so their heart rate wasn't elevated to indicate pain, or whatever. It truly comes down to differential diagnoses and appropriate assessment. I mean, so many calls come to mind that are, perfect examples. We would run out of time.
Yeah.
we would run out of time.
And I think that's one of those things where because there's so much nuance, every story is going to have a different outcome.
Mm-hmm.
Every patient's going to have a different outcome.
I think really the general gist to get from this is she's more so addressing the medics that literally won't give pain management because of bad attitudes. They have assumptions about patients without doing an appropriate assessment. They walk into a call already assuming they know the answer.
Oh, I've been out here 3 times tonight. She's not getting shit from me.
Yeah.
I've heard that.
Or you have the people that actively refuse to run a call because they don't want to do the paperwork.
Yeah.
I've experienced that. When I was an EMT, I wrote up my medic partner because we went out for a grandma that was blind, scared, fell at her granddaughter's wedding, had an S fracture of her wrist. So 2 fractures. Like, literally her wrist did this.
Ooh.
He BLS'd it to me. What
the fuck?
To my face, refused to give her pain meds.
That's lazy and irresponsible bullshit right there.
Well,
shame on you, whoever you are.
And then decided to not take her to the appropriate facility either. Family requested a certain hospital system and said which location's best, and he took us to the literal closest one, but it wasn't appropriate because they didn't have ortho.
Why is this still a conversation, guys? How often have we had it beaten into our heads? You got to go to the appropriate facility, and even if patients' families are, oh no, they need to go to this place. Explain to them. Now, your patient has ultimate say so, and we'll talk about that in a minute when we talk about waivers and stuff. That being an advocate for your patient also means you have to honor their wishes at a certain point. But
You still have to give them information. I was going to say informed consent. Information
well,
about the
but
facility.
yeah, but I mean, it needs to be informed consent too. But you know
Well,
what? It have that conversation. Stop being fucking lazy.
Mhm.
Take your patients where they need to go.
Well, and that partner, not only was it neglectful patient care and inappropriate transport, but he had the reputation for not giving pain meds literally because he didn't want to go to headquarters and have to do the paperwork.
Why are you proud of that, people? Why the fuck are you proud of that shit? I don't understand it. I've heard that for fucking years. Oh, I don't. They wear like a badge of fucking honor. They don't give pain meds for shit. I'm like, what the fuck is wrong with you? Who hurt you?
What cracks me up is I'm a candy man, but like,
Me too.
well, but here's the thing. Most of my patients aren't even like gray areas. It's either you don't need, it's either you're not really in pain or like they don't report being in pain or like they need it.
Mm-hmm. And it's not. I would argue that if you're the kind of person who wants to go the full nines with every patient complaining of pain, cool.
Mhm.
Like, cool. I don't. I'm not going to argue with you about that because, I mean, yeah, you could say that there are some that don't need it or it's not indicated. But especially if you have a wide array of options available to you, cool. Why not? Why not? It's not. You shouldn't be villainized for doing that. You really shouldn't. I choose to make it more based on genuine clinical decision making, but I do also err on the side typically of treating the pain. So it's a gray area. Choose where you're going to be, but don't be fucking lazy. That's the moral of the story. Don't be fucking lazy.
Just one last comment before we move on. I do think one complaint that oftentimes gets overlooked is abdominal complaints, abdominal pain complaints. Like they can be tachycardic and be complaining of pain and okay, is an opioid really going to help grandma if she's constipated? No, it could, arguably make it worse. But okay, if you carry Toradol is a fantastic drug for pain management. Even if they taken Tylenol at home, maybe IV Tylenol, it works a little bit different. Like abdominal pain calls are often overlooked for pain. And I understand, the whole argument with constipation, but there's so much in the abdomen. Like, what if it's, a female of childbearing years that has ovarian torsion? Extremely painful. Can we diagnose that in the field without a CT?
Mm-mm.
No.
Well, and I think not to continue the tangent, but I think where that comes from, because when I first got my medic and was first getting in the field, you weren't allowed to give pain meds to abdominal pain complaints. Like it was just flat out. At least where I worked, it was a nope, can't do it. And I think that was a typical thing for a while. Also, at least around here, we still had to call for orders when I was for any pain management when I was first coming up in EMS. Like that changed right before I got my medic.
Well, and again, I come back to clinical.
I'm just saying that's where the habit came from. That's all.
Yeah. But even nowadays, I think it comes back to you have to do a proper patient assessment. I had a lady last night actually. Textbook constipation. It hadn't gone on long enough. Don't think she was fully impacted. There was no evidence of bowel obstruction. Vital signs were literally stable. Like her blood pressure was fantastic. And literally reported shitting a brick and had a hemorrhoid that she could feel. I mean, there's nothing I can give her to help with that kind of like.
Yeah.
Unless I squirted some on her asshole, I don't know what she wanted pain-wise. Like, there's nothing to help your butt, ma'am. I'm sorry.
Do a coffee enema.
The first time I ever smelled a fucking coffee enema in the ER for a hospital clinical, I was like, what is that delicious smell? And they're like, oh, we're going to shove it up grandma's ass. I was like,
no!
Literally, it ruined it for me. It was fucking like coffee, milk, and molasses.
Oh, God.
It smelled so good, and they told me what they were going to do with it. I was like,
but no.
Yeah, I was like, I can't watch this.
So now let's get to the fun topic of overdoses and how we treat people with overdoses. Yeah. Go ahead.
I will say my internal monologue does not, on a lot of things, not just this topic, does not reflect how I actually treat a patient. Where I get frustrated with the overdose is not the fact that,
Sorry.
Is not the fact of, oh, I'm treating this person for an overdose for the 5th time today or this week or whatever. Usually it's, okay, we're gonna give this person Narcan. They're gonna wake up and they're gonna be a raging asshat to me when all I did is, return their respirations or whatever. I think that's where my frustration gets is like, bro, can we just have an understanding? You did something. I gave you Narcan. You're back. Don't treat me like shit. That's where my frustration comes from.
Yeah.
Now, I won't be nasty with them. Now, if they get nasty with me and start cussing me out, then we're gonna have a come to Jesus. Like
Yeah.
I'm gonna become your mama for a minute. I'm gonna tell you, you're not gonna talk to me like shit. But then I go right back to being nice, taking care of the
Mm.
nausea. Like that's where, at least personally, my issue with the overdoses come from. Is let's not lie.
Yeah.
Like just own it. Let's not lie. Don't treat me like shit. But besides that, how I treat them is with the same respect as anybody else.
Well, and again, it comes back to, how you talk to somebody. Like you said, is different sometimes than your inner monologue
Mhm.
or dialogue, depending on how many personalities you have. Um,
I guess I should have clarified.
but yeah, we're all frustrated by it, especially when they've been tossed in a cold shower right before we get there.
Yeah.
Please stop doing that. Please.
Yeah.
Anyway, and I will freely admit that I have been that guy who has been a dick to overdose patients. And and not just in that context. I had some anger management issues. Not okay, that sounds a lot worse than it is.
I was gonna say that was
I had
over exaggerated.
no, that was super exaggerated. I had a lot of issues just in general with emotional regulation, and like my road rage was pathological. And
It was before you
know,
had the red beard.
I mean, yes, I think we talked about that last time. All the anger just went to the beard, but that's why it's redder than the rest of the hair on my body. But I think I was also at a point in my life where I was allowing frustration and stress from the job to dictate my personality more. And I was allowing those irritations to live rent free in my head. And so there were some times where felt like I could justify it, but looking back, and now I'm not like this with overdose patients. I don't coddle them.
Or driving. He's much nicer.
I am much nicer driving. It slips out every once in a while, but
yes.
now I will still be firm with them, especially like if it's an overdose patient who has kids. And like, dude, like and I understand. No, you're not gonna save them, from all their life choices in a 5-minute conversation. Just, we'll have a conversation about it, and be like, hey, needs to be a wake up call for you. This is not good.
You can be firm without being ugly.
No, I agree. I'm just drawing that distinction of, I'm not saying I'll be like, oh, buddy, I'm so sorry this happened to you. Like, no, I'll be like, hey, man, like, this isn't cool.
Mm-hmm.
But, I'm also not going to sit here and rag on them because I know, what's going to happen.
Mm-hmm.
And so not giving them another reason to say fuck you to help is important. It really is. And I don't believe in the whole, oh, we'll just give them just enough Narcan so they can breathe and we'll sneak them to the hospital. Like, no, just if you're going to treat them, treat them. Like, well, you should treat them. They're not breathing. Treat them. But what does being a dick do?
Well, how
does it help them?
With that comment, though, I would like to specify. Now, I'm not somebody that gives just enough Narcan to return respirations to be like, fuck you. But I do have to say there is something to be said about don't slam the Narcan. Because, like, that's just cruel as well. Because they're immediately nauseous. And it's not even about us having to clean up the vomit. It's what it physically, like, physiologically does to the patient.
Yeah.
Like, that right there is hateful all on its own.
Yeah.
It is better to give it slowly. They're still going to feel like shit when you wake them up. But, like, don't slam it.
Yeah.
Because, like, they're going to vomit. They're at risk for aspiration. They're going to go into immediate withdrawal, headache, all the rest of it. Now, I do want to say that the advancements in technology and research and medications and all that, the options after Narcan with I'm sure I'm saying it wrong. I can spell it.
Buprenorphine.
Yeah.
Buprenorphine. Pretty sure that's how we say it.
I'm pretty sure. I can spell it. I can spell it.
Yeah.
with the buprenorphine coming to, it's being piloted in our area by one service that's in like 2 different areas.
Mm-hmm.
You do have to fully wake them up with Narcan. And what do we often see with the overdoses? You wake them up, they're in immediate withdrawal, they waiver because, they're ANO times 4, don't want to go anywhere, they feel like shit, they know what's going to happen at the hospital, and they go back out. They want to get rid of the withdrawal, so they do more drugs, and Narcan wears off, and then you're going right back out for another overdose.
Yeah.
Well, if you're able to talk to them and explain the way buprenorphine works, I think it's going to be a good bridge. But that's going to require providers to treat patients appropriately, but also have a good rapport with the patient to actually listen to basically your sales tactic to get them, because they have to consent to the buprenorphine. You can't give it to them while they're still unconscious.
Well, and the data with the buprenorphine trials of how many people actually don't just go get help the next day,
but follow up.
Well, but I mean, those numbers astronomically go up, period. But the long-term well-being of these patients increases significantly. And we were just talking about this before. There's a medic that we both used to work with who has actually been basically leading the buprenorphine trial in this area.
On the EMS side.
On the EMS side.
Yeah, he's
EMS
working
side.
like hand in hand with the docs and stuff.
Yes, he's a liaison with EMS in the hospital, but he's also pushing out, and actually I think he helped write the protocol for it. Like,
yes, yeah.
The dude is, he's smart as shit, but also he really
committed.
He cares about this. And I do want to have him on the show. We have to deal with some technical difficulties first of having more than the two of us on here. But we're getting there. But he was an eye-opening, wealth of knowledge for us about this, as well as the other doctor that he was working hand in hand with.
That doctor was so cool.
I love it.
You want to talk about someone who is ADD on fucking crack? Listening to that doctor, do you remember when we listened to his thing? He was talking like 100 miles an hour, and he was just like, "Oh, squirrel, and then this, and then the squirrel, and then this is the research," and you were just like, "I haven't had enough coffee for this."
So long story short. Don't be a dick for no reason. Like we said, if you're in a verbal assault situation, a whole different ballgame. You do what you got to do. But don't be the one that precipitates that, because I have seen so many paramedics over the years, and I've probably done it too. Like, I could probably go back to some situations.
And EMTs.
Well, oh yeah. Yeah, the EMTs that want to like make things worse, and then they're not the ones giving the meds to fix the problem.
Yeah, I can think of one in particular is why I bring it up. One in particular, at every job he's ever worked, he is known as the instigator, and I'm just like, but this literally didn't have to be a psych call. You turned it into one.
So I freely admit that I know I could look back over the past 10 years and see there was probably a handful of times that I could have avoided something if I put a little more effort into it. So I'm saying this coming from that standpoint, but we need to make sure that we are not the ones making the problem. Because there's a lot of people who will make the problem and then act like, oh, this guy was just crazy and I was, a hero and did all these things. No, you really didn't. You made their day a lot worse. And you made more work for yourself.
Well, and listen, if you want to say all of the nasty things about literally any patient, like not even just overdoses, but all of the things, don't say it in front of the patient. Because how much research do we have out there that like even intubated, like comatose patients will wake up like 10 years later and be like, I remember on this day this patient said this or this person said this about me. Don't literally be treating the overdose and call them, a fucking worthless crackhead or whatever you could possibly come up with. Like, just watch your mouth. Yeah. If you have a darker internal monologue, keep it to yourself.
Or an internal dialogue.
Whatever. Keep it to yourself. At least until the call is over.
So we kind of want to segue into talking about waivers, and I want to throw in a disclaimer here. And when we throw this at the beginning of every video show and then at the end of all the audio shows, follow your local protocols, policies, and procedures. We are not your bosses. We are not your educators. We have some beliefs about this, but you are still responsible for abiding by the policies and procedures of your place of work.
Well, and what we often talk about is extremely generalized.
Mm-hmm.
There in medicine, public service, dealing with people, whatever, there is always going to be an exception to the rule.
Mm-hmm.
If anything, the rule is more of the exception. But like even unless we specifically talk about like, hey, this website said this number, even some of the numbers that we throw out are generalized across like multiple sources. We'll
Yeah.
take like the average of something. But
Yeah.
anyway, so about waivers.
Yeah. So, and these are things that just because it's a policy where you work doesn't mean you can't go challenge it, but do it through the right avenue. We're putting this stuff out there because it's what we believe. We want people to think about it. We want people to chew on it. And then we want you to go solve the problems where you are. So, with that in mind, I personally, so before you talk about waivers, you need to talk about patient advocacy, because being a patient advocate should be your primary focus. You are an advocate for your patient, sometimes against their family, but just in general, when you're managing a scene, you need to be advocating for what's in the best interest of your patient. This is not about your convenience. I don't care. None of us care if you want to, oh, you just want a waiver so you don't have to ride the call. Sorry, suck it up and fucking deal with it. You're here. Like, if they want to go, they want to go. Cool. Like, don't make it another fight. Don't make it a combative situation.
Well, what kills me about waivers is if it's an actual waiver where you have to take vitals and assess the patient, you're literally doing the chart anyways. What is a couple extra vital signs?
Yeah.
And it technically takes you out of service longer. That you don't have to run another call that may be a shit show call.
And being an advocate for your patients, the low hanging fruit is that's obviously you look out for the best interest of your patients. But the catch is, and we referenced this a little bit earlier, honoring their wishes even when you disagree.
Mm-hmm.
Because that is the critical piece that not only do a lot of people miss, but I think a lot of especially when it comes to the topic of waivers, a lot of management misses. Is the patient doesn't want to go, the patient doesn't want to go. And they have that right to refuse, obviously, outside of EPC, all the things.
Again, exceptions.
Yeah. So we've kind of written down 5 myths about waivers. Might make you laugh, might make you think, whatever. But in our opinion, these are 5 like myths about waivers that we've run into over the years. Alex, I forget, you like to do the odd or the even?
I mean, I prefer even numbers.
Okay. I just wanted to ask. So, myth number 1. Anytime you go on scene, you need a waiver. I've had such a problem with this over the years. If let's say, I respond to a car wreck. Okay, cool. I get there. Every single person I talk to is like, nope, I'm good. I don't need anything. We're fine. I'm not going to sit there and make every single person sign a piece of paper, especially if they didn't call. Like if it was law enforcement that pulled up or just a bystander that called, there's no need, and especially because there are places that charge for waivers, which apparently, side note, I need to go do some digging, but apparently there's a bill being pushed forward to allow Medicare to bill for waivers.
Seriously?
Yep. But it's right now, the form it's in is only for Medicare recipients. Heck, it can be a double-edged sword.
Well, I would argue that is going to help bridge that gap is community paramedicine, which we'll get to.
but I can see it's a double-edged sword because it's cool, but it's also, okay, suddenly people, I guarantee you if that becomes law, magically places aren't going to have as many conniptions about having waivers because they're still going to get paid for it.
Well,
but anyway.
That, where I also have a problem with, you have to have a waiver, is, and we get it sometimes at our current job, but at one of my other jobs, we frequently were told, like, in the call notes, hey, this is a 4th person call. Or, this is even a second party call. If I go out to someone's house, let's say I call EMS for you. Oh, he, whatever complaint. You get on, they get on scene, and I'm the one that called. I'm like, I called for my husband. And EMS walks up to you, and you're like, what the fuck?
Yeah.
I didn't call. It's anxiety. Or, I didn't call. Literally nothing's wrong with me. And we have a general conversation, and I can tell that you're ANO times 4. That's not, the patient didn't call for themselves. The patient was not experiencing an emergency, especially if they're in their right mind. I'm not wavering that. And 9
No.
times out of 10, the patients get agitated that somebody else called for them and they're like, get the fuck off my property.
Yeah.
I'm not going to sit here and fist fight you
Mhm.
for your information,
Mhm.
name, date of birth, social, all the rest of it, for something that you didn't call for. That's a cancel call
Yeah.
or a false call, whatever.
Or like false activation of life alerts.
Yes.
Like if they meet you at the door and they're like, I didn't fall, I'm good, I just dropped my pendant,
Yeah.
we're fine. Hey, have a nice night. See ya. Bye.
Yeah.
So me personally, and again this fall, I understand that there are certain places that have policies counter to this, but I would say that those policies are ill-informed.
Yeah.
They're ill-informed, they're not appropriate, and they're not actually taking patient rights into consideration.
Mhm.
They're really not. So again, it's a nuanced topic, but I think that nuance needs to be addressed. You can't just shotgun everything.
Mhm.
Okay,
Now,
number 2.
Myth number 2. You can threaten somebody with, if I have to come out here again, you are going to the hospital. So, I mean, I have had conversations, something to that effect, but I have never told somebody they have to go because literally we legally can't make somebody go.
Yeah.
It can be a conversation of, hey, honey, you're old, you're on blood thinners. If you, fall again, something's obviously going on. We need to go be seen.
Mhm.
It's for your safety or something to that effect, depending on situation.
I think part of it too, and I think this is where an element of respect comes in, and this is usually what I'll do, is if I come out and I really feel like, hey, this patient's not going to get better, they need to go. I will pull the whole, hey, honey, like, you don't want to go now? Fine. I don't agree with it, but it's your right. If I have to come back out here again, though, how about we just go ahead and go to the hospital then? And they're usually like, okay, cool. Yeah, that works.
Mm-hmm.
Sometimes they agree to it and sometimes they don't. Or sometimes if you come back out there, they may follow up on it. They may not. But you know what? Respect them. Don't come in like a dictator and tell them you are going to go if I have to come back out here again. Because it turns into this personal thing like, oh, you inconvenienced me by waking me up. So we're going to go ahead and go since we're awake now. Fuck you. Fuck you.
Well, and then the patient's going to get defensive. They're not going to want to call, even though, maybe
No.
they do need to go. Now, I will say, when it comes to waivers, I have worked at a place where crews were literally talking patients out of going and threatening them with, oh, this isn't, a hospital, which that's a whole other conversation.
Mhm.
But they were basically telling people like, you're going to sit for hours and hours and hours in triage and like, we're just not going to do it. They were talking patients out of going that did need to go.
Mhm.
So this service put into place a policy where if you were going to waiver somebody, you had to call a supervisor for permission. And I was like, I did it at the very beginning and it turned into this whole fucking mess because whether the supervisor agreed with it or not, the supervisor is not a doctor. They have no fucking authority to talk to the patient. Now, if it's a patient that needs to go to the hospital, that is actively refusing to go to the hospital against medical advice, sure, getting a second opinion is good, but I'm still not going to call a supervisor. I'm going to call a fucking doctor and be like, doc, this is what's going on. Can you talk to this patient? I'm not going to call a supervisor. It just because you have that title doesn't magically make it to where you can force patients against their rights if they're in their right mind to go to the hospital. And what it was turning into when you called, it could be for the most stupid complaint or even a second party call. And there was one supervisor in particular that was like, would you run a 12 lead? Why the fuck am I running a 12 lead call on a second party or a third party psych call?
It's liability-based medicine.
Well, I know, but literally I was like, you should not be talking patients out of going if they need to go. Well, I mean, in general, you should be having a general conversation, but also you need to be doing an appropriate complaint assessment for the waiver as well. And I would argue that your documentation for a legitimate waiver should be as in-depth, if not more in-depth, than your actual chart. You should have the conversation with a patient who has an actual medical concern or thing going on. What?
You and your narratives. I can imagine her waiver narrative being like, 5 pages long. Like,
They usually are about 4
his
paragraphs
big
long.
toenail was properly shaped, and
Shut
his
up. They are usually about 3 to 4 paragraphs long. Bite me.
Anyway.
But it should be in there that, they understand the liability, the risk of not, getting appropriate assessment. So you shouldn't be threatening, but you should also be having genuine conversations. Now, and this ties in kind of with this. I was called out to an overdose, turned cardiac arrest. It was reported cardiac arrest, CPR in progress.
It's always a fun time.
Right? So I get on scene, and all of a sudden this dude comes like hauling ass out of this like deplorable house. And I mean, his chest is red. I mean, he looks friggity fucked, sopping wet. He kind of stumbles towards me. I put my hand on his shoulder, keep him from like falling face planting, basically.
Yeah.
And basically what it turned into is he had overdosed. Everyone inside gave him like 8 of Narcan. Dumped a bucket of ice water. There we go. On him, and he came back. Now I had multiple people on scene telling me that they did do compressions. Well, by the time we get there, he's refusing vitals. He's saying, no, I'm okay. He looks like shit, but he's ANO times 4.
Mm-hmm.
So with something like that, it wasn't just the fact that he overdosed, but like if they did adequate compressions in his chest, like you could friggity fuck some stuff up if you broke, the chest and such. So he was refusing vitals. Well, he wouldn't let me do anything. He just wanted me to leave. And I mean, law enforcement was there because of the situation. Well, so I called a doc because I was like, if anybody's going to give orders, let me see if a doc would, because it's not just about the overdose. And I was being nice to him. He was being ugly, but we were having a general conversation. And I tried to explain to the doc, like, there is physical evidence that I could see, and everybody on scene is saying they did compressions. Like, he is not comprehending what's going on. Well, it turned into, you have to let him waiver. Man, I documented the ever-living shit out of that call.
I guess that kind of dovetails to myth number 3, which I haven't seen much recently. But I remember being told this very specifically at one of a mutual former place we both worked. You withhold treatment if the patient says up front that they do not want to be transported. So literally, if you were called out for a breather and somebody was actively wheezing but said they didn't want to go to the hospital, you weren't supposed to give them albuterol.
I've also seen that with Zofran, that you're not allowed to do it, not at the current place, but just like in the past, I've seen you can't give Zofran for, the most vague whatever, food poisoning, pregnancy, whatever, and then let them waiver, and you have to put them on the 12 lead, which pharmacologically I understand. But anyways.
Well, and I have no problem admitting that I actively disobeyed that policy.
Oh, 100%.
Because that's just radically inappropriate. Like, okay, Zofran, stuff like that, I can see. If we're going to give you, I'm not trying to minimize people who are vomiting. Just, that's not a life-saving drug. There's a difference. But I wholeheartedly abhor that mentality of, oh, well, we're not going to give you anything if you're not going to go to the hospital. That's just fucking, like, fuck you. You're more likely to get someone to go if you actually like treat them appropriately with respect. And if they still don't want to go, guess what? It's their fucking right to refuse. No matter what you've given them.
Well, and I've seen not places, but like some people that won't do an appropriate assessment end up transporting a diabetic, and then the diabetic is like, oops.
Well, and I also have to throw a caveat in here. I don't, when it comes to narcotics, whole different ballgame.
Well, yes.
Whole different situation. If I'm giving you narcotics, it is irresponsible of me to leave you there.
Oh, 100%.
So I need to throw that caveat in there for you little whiners and hole punchers. Like, that's different. That's a different thing.
We're talking about like albuterol, waivers for like, your general asthma. Yeah, Narcan, diabetics, etc. Stuff like that. Let's
Which goes
see.
to number 4.
Yep, fifth number 4. If you give someone medication, you have to transport them. I know we kind of touched on this already.
A little bit, yeah.
So I mean, that's another myth.
Obviously, use discretion, like with narcotics. Don't give someone ketamine and then waiver, like,
Or
because at that
leave
point,
them with law enforcement
yeah.
not being monitored.
But like, because at that point, technically and legally, one could make the case that if you've given narcotics, that has the potential for inducing some level of altered mentation, which removes the ability of someone to make informed consent.
Mhm.
So be careful with that one. Again, follow your local protocols, policies, and procedures.
And do appropriate assessments.
Yes. Number 5. This is one of my favorites. The patient can be forced not to waiver by law enforcement. I have a little fun story with this one.
Go
So
for it.
there was one time I and I have to throw out there, I love all of our cops.
Mhm.
I've always gone out of my way to maintain a healthy, good working relationship with all of our cops. I still hold individual cops responsible for when they do this kind of stuff, and I vocally challenge them on scene now. When it's the whole like go to the hospital or go to jail bullshit, I outright challenge them in front of everybody. Say no, absolutely not. We're not playing that game. If I'll ask them, have they done something that you should arrest them for?
Mhm.
No? Okay, then we're not having that conversation. But that aside, I went out to a large chain retail store for an overdose in the bathroom. Got this guy, gave him some Narcan, woke him up. He was the nicest dude. Like, he was honestly probably the nicest overdose I've ever met. Like, just super chill dude. Like, wasn't trying to hurt anybody. You know, he was a young guy. I don't think he had family. I don't remember. But he was getting bullied with the whole, like, you know, you're going to the hospital or you're going to jail. And so I finally told him, I said, dude, we're just gonna go around the corner and drop you off. I was like, I'm not playing this game. So literally, we just, you know, and I told him, I said, look, I respect our officers, I respect these guys, but what they have told you is incorrect. So what we're gonna do is we're literally just gonna drive around the parking lot. We didn't leave the property. We just drove around the parking lot, kind of out of sight, you know, by another store, and you know, we crossed all of our T's, dotted our I's, did everything. I think I even got a 12 lead on this guy. Like, we did everything.
Yeah.
And he didn't want to go. I said, dude, and he's like sobbing. Like, he is so upset because he just doesn't want to go to jail. And I said, dude, that's not fair. That's not fair to you. So I let him go. It's not fair to bully people like that. That's harassment. That's inappropriate use of authority.
Well, I mean, the threatening is assault. Like,
I mean, technically, yeah. I mean, they're not threatening him with harm, but it's manipulation.
Jail,
yeah, but I mean, if you want to split hairs, they're not technically threatening him with harm, but it is an abuse of authority. However you cut it, whatever you name you give it, it's an abuse of authority.
Manipulation,
Yeah,
gaslighting.
it's not okay. So let's not do that. And at the end of the day, like we said earlier, waivers are not about your convenience. If someone called, if they want to go to the hospital, take them. Does that mean that everybody that calls 911 needs to be transported?
No.
And I think we're running out of time, so we'll have to push this for the next episode.
Well, honestly, with
this whole
good
conversation.
and with good conversations in gray areas, I definitely think should everyone be transported, and even community like the usage of community paramedics needs to be like an episode on its own. Like,
yeah,
we
it
can
does.
include some other stuff. Again, there's a lot of gray areas, but I think part of the problem with the general public is they don't know what their PCP can and can't do. They don't know what urgent cares can and can't do. But also, not all ERs are equipped to handle the same stuff. So, like, that's why we need to advocate for our patients and change the tone of our conversations.
Yeah. This was good. I'm actually kind of looking forward to the next episode. I mean, this isn't really a two-parter, but like, I think we've set up for a good episode coming up for talking about should everyone be transported? How does community medicine play into that? I think that deserves more than a 5-minute add-on to an episode.
The way we share stories and talk about things, we will never make it 5 minutes.
Well, in our own interactions with community medicine, at least I've had quite a bit.
I did too, in a certain town.
Well, and we were the hospital system that I used to work for during COVID utilized a lot of, it was even before they had like a formal community paramedic setup, But like they would send us out, so it's during COVID to draw do blood draws and like give antibiotics to people at home and waiver them
Mm-hmm.
so that they would stay out of the hospital. But that's a whole longer conversation we'll have next time. Anything else you want to throw in before we say goodbye?
The next conversation is going to be a good one.
Yeah, it is. If you learned something, awesome. Tell your friends about it. If you were offended, good. Go complain to everybody about it and tell them how horrible we are and how mean we are and how much we hurt your feelings. That's all we got for today. Almost said tonight. See you guys next time. Bye-bye.